Well, good afternoon, everybody. Good news is if we put everybody together, we could have a good time, but good luck out there, okay? So basically what we're going to be talking about is TMD or TMJ and craniofacial pain and the oral manifestations. Basically what that means is how the jaw works and what happens in the mouth and what you actually see when you're looking at an EDS patient. So basically, when you actually look at this, you're actually talking about two questions. You're talking about the cervical craniofacial pain and the oral manifestations. Basically, what kind of pain is generated by the jaw, the head, the neck, and how it actually intertwines with everything. And we're going to actually talk about why they occur and why they occur with such frequency. We're also going to talk about what you do to treat the patients and help them. So, why are oral manifestations and temporomandibular joint observed in so many EDS patients? Well, number one, they're all across the full spectrum of the EDS patients. Number one, they're in the classical, vascular, the kyphoscoliotic, the end-terminal conversion demoparaxis, the TBC, and myomatrix, as well as pterygoid and musculoskeletal EDS patients. In other words, all across the entire board, TMJ is allowed to be inflicted. So one thing, there's one study that was done, we were actually looking at EDS patients, and 90% of the EDS patients had some type of TMJ problem. I personally did a study, and out of 200 EDS patients, we found 195 with some type of TMJ problem. So needless to say, it's fairly prevalent. Now, the one thing that is most paramount in this is that there is no one specific type of TMD or TMJ. It happens in different volumes, different types, different incidences. So basically, there's nothing you can actually look at that will actually give you a hint as per what's coming and what's not. Okay, now, here are classic TMJ symptoms and disorders. Things that you look at and things that the patient will tell you about and the problems they have. Number one, some patients can't open their mouths, okay? Some can't chew, some have pain in front of the ear, some have pain behind the ear. Some have headaches in the temple, the forehead, the lateral side of the head, above the eyes, behind the eyes, the base of the neck. It's all prevalent, but they're all from different sources, and we'll talk about that. Now, we're talking about migraine-type headaches also. Believe it or not, this symptom is the symptom that actually gives rise to migraines. Two sources of migraines, temporomandibular joint input and from the rear, and we'll actually talk about what causes that. Now, the inability to turn the head and the neck, the thing we found and the one thing that's become more prevalent, in about 30 TMJ patients that I see per day, I would say probably about 25 of them have primary cervical problems. And basically what happens is they won't be able to turn their head in one direction or the other. We found out that when the neck is actually out of position, cervical vertebrae are rotated, that's actually torquing the jaw and actually causing popping and or pain. So it's turned out to be more of a cervical situation rather than a pure joint situation. Now, the inability to get to the posterior teeth together, basically we'll actually have swelling in the joint when it actually dislocates. The fullness and pressure and pain in the ear, we end up getting a lot of referrals from ENTs. Basically the situation is that the same nerve that goes to the back of this joint is a nerve called the deep temporal nerve. The deep temporal nerve is a branch of the mandibular nerve, which is a branch of the trigeminal nerve. Imagine that. And basically what happens is it's the same nerve that goes to the ear canal. So basically what happens is pain in one will be thought to come from the other when in fact it's all the TMJ. Now, the popping and crepitus in the joint. Now this is the basis to what we're actually finding. Now we talked about limitation of opening, inability to chew, pain in front and behind the ear. Basically what happens is the joint itself is a ball and socket joint, which we'll see. And what happens is that the crepitus is caused by the cartilage that actually sits between the two bones, okay? So what happens is that the cartilage is actually held in place by two lateral ligaments, a medial and a lateral ligament. And what happens, this is a lot like a child's bonnet. One ligament on the outside, one on the outside. And what will happen is that ligament, that cartilage, pardon me, will actually flip back and forth. And that's the noise that you hear. So if in fact the cartilage is forward and you go to open, you'll pop onto it. If you go to close, you'll come off of it. If you get crunching, a lot of times you're just on the edge of it, and then you load it and you'll actually hear a crepitus, like a crunching. So that's where a lot of that noise comes from. Now, usually when you look at somebody and you're actually assessing this, when they open their mouth, when the jaw actually goes to one side, usually that's the side that's affected the most. That's the side that's literally not relocating onto the cartilage. Again, that's the limitation of opening, and it will give you the pain in front of the ear, okay? So let's actually go to the next slide. And what we're talking about is hypermobility in the TMJ. It's that ball and socket we were talking about. So the ball actually will rotate for the first 33 millimeters of opening, and then it'll actually slide or translate for 40 to 55 millimeters of opening. Now, EDS patients have hypermobility, so a lot of times that opening can get as high as 75 millimeters. It's a running joke about putting the tennis ball in your mouth or sticking your fist in there. This is a stupid human trick that we see. Okay. Now, there are a number of muscles that run this joint. There's the temporalis muscle, which is the one on the side of your head, the masseter muscle, which is the one in your cheek, internal pterygoid underneath the angle, and the external pterygoid is the one that removes your jaw from side to side. So one thing that does happen is the temporomandibular muscle, the temporalis muscle, actually starts behind the crest of the eye, goes to the vertex of the head, actually goes to behind the ear. So what happens is that it has multiple bands. So if you're sore in the front, that means your jaw is being pulled forward. If you're sore in the middle, it means you're clenching straight down. If you're sore behind the ear, that means your jaw is actually retuded. So it acts almost like a big meter, and you can actually tell which side the problem is located. The muscles of mastication have to do with the masseter muscle, which is the one you feel in your cheek. When you actually close and squeeze your teeth together, you actually feel that muscle physically bulge. Now, a couple things happen when this occurs. Number one, it'll make the teeth sore, and some people think that they're having tooth problems when in fact it's a referral pain from the masseter. The other situation is, and we see it more than anything else, the insertion of the masseter is underneath the cheek, and it's just above the first molar, the upper first molar. So what happens is that what it'll do is actually put pressure on a nerve they call the middle superior alveolar nerve. Basically, it's the nerve that goes to the first molar. And what it does is it'll actually cause compression, and it'll actually make you think that you're having a toothache. And we see more upper first molars with root canals, when in fact it's not the molar itself, it's actually the muscle that's causing the spasm. Okay. Now, the one thing that we just talked about was the muscles of the neck and how those actually works. There's actually two major muscles. One is called the superior pharyngeal constrictor, one is called the middle pharyngeal constrictor. So if you put your teeth together and squeeze right in front of the masseter and right between the angle of your jaw, there's a soft area, and that's where the quote-unquote buccinator muscle sits. And the buccinator muscle actually goes interiorly and goes behind the body of the mandible. Well, the superior pharyngeal constrictor starts from the fascia between the masseter and the buccinator. It actually starts there and goes all the way around the back of your throat, comes out the other side. And what the situation there is that it'll actually cause basically a problem with C1, 2, and 3. In other words, it actually attaches to those cervical vertebrae. So if you actually stick your jaw forward, you can actually feel the torsion against C1, 2, and 3. Now, in plain English, these large muscles connect to your cervical vertebrae, and they're quite literally pulling jaw from side to side. In other words, the jaw can pull this vertebrae out, or the vertebrae can pull the jaw out. It goes back and forth. Now, this is what they affectionately call part of the CCI, the cervical cranial instability. Now, this is a picture of what it actually looks like, but what you're looking at is the superior constrictor going around the back of the pharynx. Now keep in mind that if you have a sleep problem, if you clench your teeth, that superior pharyngeal constrictor will actually constrict, and a lot of times it'll cut your airway by 50%. Therefore, you have problems sleeping if you're clenching in your teeth at night. Now there's one more situation. The superior pharyngeal constrictor goes to C1, 2, and 3. The middle pharyngeal constrictor actually goes to C4. It comes from your hyoid bone to the odontoid process, which goes to C4. So between your hyoid bone and the area in your cheek, the positionings of the first 4 vertebrae are actually sometimes dictated by this sense. So what tends to happen, and the things that probably you'll see, I don't have the x-ray on this lecture, but if you go to my website, you'll actually see 3 x-rays in a row. You'll see one where the vertebrae is in the correct position, the dens of the C2 is right in the middle. And you'll see it rotate from side to side. The side that it rotates away from is the side that will cause the deflection. So you'll actually see the mandible actually can't. And that actually was causing a lot of the popping. I have patients who come in, the jaw be popping like crazy. We have a procedure that we do that we actually rotate those vertebrae back in. And the popping goes away almost simultaneously. Now, why is it so painful? Why are there so many debilitating headaches? So classic TMJ triggers the muscles and it causes spasms caused by stress, clenching of the jaw, ischemia, osteoclastic problems, compression of the degeneration and neurological input from the trigeminal nerve, which is there was potential TMD input for the migraine source. So in other words, if you clench too much, if you've actually caused degeneration of the joint itself, if you have actually spasms, it actually cause pain to be generated into the trigeminal nerve, which actually it's the motor nerve that goes to all the muscles in the body. It's also the sensory nerve that goes to those muscles. So when that happens, it can actually cause inflammation of the nerves and of the joint itself. It'll cause the condylar displacement. Now, muscle spasticity is a problem. Again, the trigger point of TMJ pain for the need for the EDS patient is displacement of the cervical vertebrae. Now, one of the situations that you see when you talk about head pain is a thing called the occipital neuralgia. Now, the occipital nerve, when you actually look at behind your head, the lesser occipital nerve comes out between your skull and C1. That's the one that goes behind your ear. The greater occipital nerve comes out between C1 and C2, goes to the occipital muscle in your skull, goes to a big piece of connective tissue in the top of your head called the aponeurosis, and then goes to the frontalis muscle. Now, if you feel above your eye, you'll actually feel a notch there. That's the first branch of the trigeminal nerve, okay? And that nerve basically has a branch that goes around the eye and behind the eye. So occipital nerve and occipital neuritis actually generates from the C1, C2 area, just to keep you going. Now, the one thing that happens is that the trigeminal nerve is a very large nerve. It actually gives you 35 to 40% of the input to the brain from the face itself. Now, oops, wrong direction. Now, when you talk about treatment of TMJ problems, you're assuming that the hypermobility is a generalized situation. So what we try and do is prophylactically keep you from doing a few things. Chewing anything that's tough or repetitive, opening your mouth too wide, clenching in your sleep, things that actually cause the problem. But the one thing we find out is that postural alignment will help it tremendously, especially with cell phones, computers, the heads are down in an anterior angle. Now what happens is, believe it or not, for every 2 inches your head goes forward, it actually doubles the weight of your head. So it actually will cause strain in the upper back and neck. And what we also need to do is minimize the muscle spasms, and that'll actually help the discomfort lessen. Now, for actual treatment, the mechanical treatment that a doctor would give to you, the most common thing people hear about are custom splints. Those are the bite pieces. And the one thing that most doctors get into is, number one, they don't look at the cervical vertebrae for position, and the mandible will actually be torqued. The splint itself will actually probably be the wrong position. And so the splint itself will not actually do much. The biggest problem we run into, though, is if you use a soft splint, that actually increases the problem. If you use a splint that's too thick, that causes you to clench even more. Now, prolotherapy is, again, dry needling, and I'm not the biggest fan of that because I use Botox a lot. And what you're going to find is that there's less pokes with Botox than there is the prolotherapy. Medications we know about, you're talking about muscle relaxants, anti-inflammatories, and pain medication, which sometimes help the problem. But here we are talking about the botulinum toxin again. There actually is what they call a migraine protocol, which actually will help the TMJ patient. Now, we don't have to go quite as many places, but if you do the masseter and the temporalis, what that tends to do is decrease the amount of tension that those two major muscles can cause. Now, when you're doing the migraine protocol, you do the forehead, you do the area above the eyebrows, and usually about 4 places across the base of the skull. And believe it or not, that actually knocks down the migraine. And we're good for 4 to 6 months. I've got one of my patients here that we do every 4 to 6 months, and it actually keeps her from problems. Now, other things that we actually use are things called deep heat, and it relaxes the muscle fibers. And the protocol we use is what they call a 10-3-10 protocol. That's warm, cold, warm, opens, closes, constricts, and dilates the blood vessels. We also use a cold laser, which is a low pulse laser, which actually does a very nice job of relaxing the muscles. Physical therapy actually helps a lot of people, and what we'll actually see is some people actually find it very helpful. Now, the last thing, the surgical option, we try and stay away from that as much as possible. In 20 years that I've been doing EDS patients, we haven't had to surgerize one, okay? Yeah, so we're able to keep, number one, the cutting to a minimum. Number two, the one thing they don't tell you about this is that your hip can actually take 200 PSI. Your jaw generates 600 to 800 PSI, okay? So the rib cartilages they put into the Teflon or whatever they come up with, within 2 years is usually destroyed, okay? So what we try and do is stay out of this little monster so it doesn't actually cause more problems. Now, the one thing I would probably say to you is be conservative as you can. The situation is that when we actually look at practitioners who actually attempt to treat this, they have to have a really good knowledge. And believe it or not, I get calls from all over the United States, Japan, Tokyo, from Moscow, wanting to know what the protocols are for something like this, what the vulnerabilities are. And so if you have a problem with your doctor and they want to know, don't have them hesitate to call me. I can get them out of a lot of problems. Now let's talk about the next thing, the oral manifestations. And we're going to talk about the gums, the frenum, the tongue, the palate, the bone, the teeth, the occlusal situation, and the cervical neck and aberrations. Okay, the oral manifestation of the periodontal tissue, that's type 3 collagen, and the fibroblasts in type 3 collagen alter the production and secretion that affect the physical and thermal stress. In other words, the thinness and the fragility and the bleeding tendencies are actually all things that you see when the stress increases. Now, the one thing that is really interesting is that the blood vessel level below at the bottom of the gum tissue is really aberrant. In other words, there's no formation to it. And what it tends to do is it limits the oxygen and the blood supply. That's part of what makes the tissues so friable. And the EDS type 3 are probably more prone to this. Now, other things that happen, the manifestations, the periodontal tissue and mucosal tissue are very inflamed. And that's why maintenance is very important. The onset of periodontal tissue situations are very common. Gum recession is very common. Abnormal light reflection, believe it or not, when you look at the gums, it'll actually reflect the light due to the aberration of the blood flow. The tissues are susceptible to impact, irritation, and surgical intervention, and they inflict from deflection. So basically what happens if you actually try and do surgery, you have a problem, the tissue is very fragile. And the fragility sometimes really compromises your surgery. It's not unusual that we have a large surgical area. We actually ask a plastic surgeon to actually come in and do the closures. Because number one, they're surgical and the suturing mechanisms are much smaller and less torsion on them. Now here's the gum reflection that we were talking about. You see where the light will actually bounce right off of those things. Now let's talk about the frenums. Now the frenum is the piece of gum that goes from your lip to your to the body of the mandible and or maxilla, and it's a small fold of tissue, and it's inferior frenum. Now this is a missing lingual frenum of the tongue. Usually there's a band that goes from the floor of the mouth and goes to the tongue itself. And this is, believe it or not, this is what gets babies in trouble when they're doing suckling. The frenum from the bottom of the floor to the tongue itself. Well, EDS patients don't have this problem, but the problem is you end up with EDS. Yeah. Okay, the oral manifestations of the tongue. There's a thing called the Gorlin sign, which I officially call this the stupid human trick, where you can actually touch your nose with your tongue, okay? Now, keep in mind that the tongue's very soft, and you'll actually see scallops in the outside of the tongue from when you clench it. And you're gonna actually see more malignancies and more ulcerations in an EDS patient. And this is the Gorlin sign, the stupid human trick, tongue to the nose. Now, when we talk about oral manifestations of the palatal vaults are pronounced and they're high in most cases. They cause abnormal facial growth, can produce sleep disorders, and increase the tendencies for the TMJ problem. Now, this is a typical high vault. Now, what happens is that the width of the vault will actually close, and what it does is it actually takes the base of the skull and actually lets it collapse. Therefore, the jaw is narrower than it should be. The nasal cavity is higher than it should be, and the area in the rear of the throat where the air passes the pharyngeal space is actually collapsed. So one of the things that they look at when they're actually doing sleep evaluations is how much they can actually physically stretch and open up that vault palate to actually increase the airway and the air volume. Now, the one thing that we all know about EDS patients is they have problems with bone. You have osteopenia, deficiency in the collagen, decreased bone integrity, decreased bone stability, the acceleration of the periodontal recession due to the tooth movement. And the one thing that we notice is that when kids go in to have their orthodontia done, orthodontia will take half the time that it takes normally. But what happens also is that if in fact they don't have fixed stabilizers after the orthodontic bands are removed, they'll actually relapse in 18 months. The bone is that unstable. Now, the oral manifestations of the tooth, you can see what's happening here. You have dilacerated roots, elongated roots, molar fusions, pulpal calcifications, that's in the tooth itself, where the nerve is. You actually have calcification there. The tips of the teeth will be really long. The grooves will be really deep. The teeth will actually split. You have congenital absence of teeth. You'll have supernumerary teeth. You'll have microdontia, teeth that are smaller than they should be. They have a thing called dentinosus imperfecta and cemento-enamel junction problems. That's the actual structure of the tooth and the enamel and how it bonds to the underlying areas. The appearance of teeth, believe it or not, are amber and they're translucent. And teeth can easily fracture. Early tooth loss, regardless of normal hygiene, is normal. So basically, most important step in dental care is for the EDS patient to make sure that your dental care provider understands your condition. You can confirm that you understand this: the mucosal fragility, the wound healing, the orthodontic therapy, what we just talked about, and the posterior teeth have high cusp and deep fractures. Oral Anesthesia, though, is the biggest problem with someone that's actually having their work done in your EDS patient. The anesthesia is quickly dissipated when it's injected. So what we found out, and what I found out from doing it for multiple years, is number one, the anesthesia itself will only last 3 to 5 minutes. So if you're going to have work done, it has to be done quickly. That's one. Number two, the most potent way to actually make the anesthesia work is to actually do what they call an infiltration around the tooth. That's direct injection right at the base of the tooth, and actually that will last longer than some type of nerve block that you've seen. So in conclusion, you're the best advocate. Make sure that your practitioner knows what they're doing, they understand your challenges for the EDS patient, and please be conservative. Try and keep as much surgery as you can to a minimum. Okay, thank you. Okay, there you go. All righty.
Okay, thank you, Dr. Mtakides. Just a few questions here from the app. See if I can pull this up. Okay, the first one is, after dislocating both ends of the left clavicle and the left glenohumeral joint, can the misaligned joint strained or stretched muscles cause the left jaw to dislocate also?
Right, basically what happens is the clavicle basically joins right in the suprasternal area, okay? Well, believe it or not, the sternocleidomastoid actually goes from the mastoid process to the suprasternal area, and basically that's part of the stability of the head and the positioning and the rotation. So what it'll do is it'll make the neck unstable, and it'll actually allow the clavicle, due to the bone dislocation, to dislocate. Okay. And it causes pain, basically. Okay. Yeah.
Okay, thank you. Let's see, another one. Do you have experience with Eagle syndrome patients who have had their stylohyoid ligament and styloid process bones removed? And if so, have those patients had particular difficulties after these surgeries?
Yeah. Basically what the Eagle syndrome is, and the things you see mostly with Eagle syndrome, is that there's a process that goes just medial to the back area of the jaw called the styloid process. And the Eagle syndrome, that styloid process will actually extend. It'll actually go, in some cases, 20, 30 millimeters long. The stylohyoid ligament actually goes from the styloid process to the hyoid bone, and there's also a stylotracheal ligament that'll go down that far. What it does is it keeps the hyoid from moving. But when they do that removal, what they do is they have to deflect the SCM, and it's right close to the carotid. So it's very tricky surgery, and you have to be very careful.
Okay. A few more coming in. Another one. I get intense pain in a small spot behind my ear, kind of like I'm wearing glasses that are too tight. Is this pain from TMJ?
This is a cutie, okay? Basically what happens is if you feel behind your jaw, but in front of the SCM, if you feel a knob there, okay? That knob, believe it or not, is the lateral process of C1, the first cervical vertebrae. So when it's rotated, that will actually generate pain at that point. Now, what it also does is it'll actually rotate forward, and sometimes it makes it hard to swallow, and that's why the pills get stuck, okay? But in fact, what it's doing is actually putting pressure on the sternocleidomastoid again, and that's the pain that's generated due to the positioning of C1.
All right, thank you. I just refreshed, and there are a few more. In an EDS patient with severe TMJ pain that causes clenching, is it common to be diagnosed with macroglossia? Sorry for mispronunciation.
Glossia.
Glossia, thank you. And is this a misdiagnosis?
The answer is probably. Bottom line.
Right. My daughter, who has HEDS, has had intractable TMJ pain from a car accident 2 years ago. When splint therapy did not work, she was treated with arthrocentesis and Botox. Arthrocentesis and Botox. The Botox was ineffective. Is this common in people with EDS?
Okay. So basically what happens, and the things they don't tell you, is when you're in a car accident, the whiplash, quote unquote, the head will actually rotate front to back 130, 140 degrees, okay? So what it actually will do will displace C1, 2, and 3 in the neck and actually go as far down as C5 and 6 and further for the neck itself. So what it does is it actually causes compression and rotation of the vertebrae themselves, which actually causes compression of the nerves we were talking about, the occipital, greater and lesser. It goes to the phrenic nerve, which goes from C3 to C5, which goes to your diaphragm, makes you short of breath. So there's a number of things that occur that that people actually don't assess when they're actually looking at this. You can put as much Botox in you as you want, but you have to actually do it in the right spot. Okay.
Okay. Here's another one. Can you describe how to discuss anesthesia approaches a bit more for dental procedures?
Okay, we just talked about that, but sedationist, quote unquote, is the one anesthesia that we use for EDS patients. It tends to be more effective. Sedationist is the name, okay?
How do you spell it?
C-I-T, sedationist, okay? And basically what happens is, like we talked about, the infiltration will work better than blocks, okay? And it'll tend to last longer, but you have to go quickly, because if you don't, it'll wear off very quickly.
Okay.
Okay.
Okay. Night guard seems to make pain worse, but recommended by dentists to protect chipping. Is there a best practice here?
If the night guard makes it worse, basically we got another situation. Number one, if the night guard is too thick, it'll make you clench more. If it's in the wrong position, it'll make you clench more, okay? If it causes airway restriction, it'll cause you to clench more, cuts down your airway volume, and you'll actually get a headache from it because the pulse oxygen is decreased. Pulse oxygen, if it gets below, much below 95, it'll actually start to affect your major organs, your heart, your lungs, your liver. So what we try and do is try and keep that airway open. Keep the clenching to a minimum.
Okay. Thank you. Here's another one. Are spacers to widen the area of the top of the mouth an issue with EDS?
Well, basically what they actually try and do is open up the airway, okay? And the biggest problem is that they can open the airway, but unless they maintain that position, it's going to collapse. EDS, just like the orthodontics, is very unstable.
Is it possible for EDS patients to have a pronounced frenum under the tongue and be significantly tongue-tied?
Yes, it is. The answer is yep.
So here's one. If you do start to lose your teeth, are implants successful?
That's a big problem with EDS patients because we know that the bone is unstable. That's why the teeth move so quickly. That's why you have the recession and have the gum problems. As a basic rule of thumb, unless there's a major problem, we probably don't recommend implants themselves because of the fact they're just not going to work well.
Okay. How do laryngeal spasms fit into all of this?
Okay, that's part of that cervical situation, okay? You get down to about C4 or C5, it actually goes right to the larynx and the voice box itself. So compression and or rotation from weakness, the ligaments that actually keep the spine in place will actually cause compression and hence produce our spasms.
I wore my joint down to a flat surface. What now?
What now? Now, the one thing that we found is, number one, what caused you to wear it down? Did you clench? Did you have pressure? What's the situation? So basically what the thing is that you have to open that space up. Now, the thing we found, and the reason we haven't had surgery, is a lot of times we'll actually rotate the mandible back to position, okay? And at that point, we actually, believe it or not, this joint is only about 10 to 12 millimeters away from the carotid artery, high blood supply. So if you decompress it and keep it in position, believe it or not, you can cut the pressure off of it. You actually can now allow the tissue to build up in the back of it, and it'll actually function, believe it or not. But what we're trying to do is stay out of it, try and do any actual repair to it, because believe it or not, the repair is sometimes worse than the problem.
I can believe it. Can you comment on chiropractic approaches to TMJ care?
Okay. All right. The biggest problem we see with that, and believe it or not, TMJ and EDS have a thing called pontus ponticus. Okay. Basically, on the anterior the superior arch of C1, sometimes a bone arch is formed over the vertebral artery. So what happens is when the chiropractor does the high-speed adjustment on you, he can actually injure that artery, okay? I don't know if you heard about it, but the Playboy Playmate in LA last year had this done. She went home and bled out because of the injury to it. So as long as there's no problem with the vertebral arteries, I would look, between you and the fence posts from C3 down, they can do whatever they want. C1 and 2, I'd have them stay away from you.
What are your suggestions for wisdom teeth removal for HEDS for heads?
Well, basically you have to have an oral surgeon that understands what he's doing. It's about that simple. Sometimes there's no way you can get around it, and you have to have an oral surgeon that knows, number one, the jaw has to be supported. Number two, there's going to be hemorrhage. Number three, the suturing has to be very precise. The biggest problem we run into is when the jaw, especially with pressure on the lower jaw to rotate the teeth out, and literally you go down and rotate. What that happens, it'll actually dislocate the jaw and cause pain. I have one lady back here that's
Okay, we'll take one from the audience and then go back to the app.
As a teenager, I had a softball knock my jaw out of joint. As I'm getting older, these teeth are deteriorating and falling out. What's some things I can do to prevent more damage?
to the teeth of the jaw. Teeth? Well, basically, unfortunately, to the jaw itself. Okay, well, the thing they don't tell you, when you take the strike from the left-hand side, it actually cause the right-hand side to dislocate. Okay, that's one. Number two, the impact basically will loosen the alveolar bone, quote unquote. That's why you have the mobility, and that's why the teeth are loosening up, getting ready to fall out. So the basic thing is make sure that your dentist keeps them clean, number one, stents them, number two, and make sure that there's actual support for them. And that'll keep them in as long as possible.
How could she do the support?
Yeah, there's multiple ways you can do it. Either you can use a fixed retainer, or you can do bonding. There's a lot of different things that he can do to actually physically keep those. He can add bone to the mandible itself. Lots of things he can do to actually beef it up so it's tight.
Thank you. Any suggestions to what a heads patient's dental hygienist should know?
Basically, you know that your patient is going to be as fragile as can be, okay? So instead of cleaning your teeth every 6 months, you clean them every 4 months. You actually teach the patient to use hydroflosses and or things that actually will flush the tooth. You have to floss a couple times a day. You have to actually brush your teeth 3 or 4 times a day. Everything just has to be as clean as possible. It's that simple.
Do you have any thoughts on gum graft surgeries for those with EDS? Do they last?
Unfortunately, the gum grafts, number one, they heal not exactly the way they're supposed to, but what happens is when the bone actually starts to shrink, the gums will start to shrink around them. So it's one of those, I'm not going to say chasing your tail, but sometimes you're chasing your tail when it comes to this.
Here's another one. What are your recommendations to help with laryngeal spasms? Mine seems to get worse when exposed to certain odors like bleach or seafood.
The biggest problem is it's what they call neurologic input, okay? So unfortunately, you might actually have an allergic response to bleach or seafood. So I would try limiting the exposure to that and see what it does.
Okay, great. Thank you. And looks like we have a clarifying follow-up question from the wisdom tooth question. So I want to clarify, impacted wisdom teeth removal with cervical instability. Suggestions. Thank you.
Inform your oral surgeon of what's going on, and he's going to have an assistant actually maintain the support on that mandible and or head when the extractions are being done. There's no other way to do that.
All right, great. That looks, I'm going to refresh one more time on the app. That looks like the last app question we had. And I was about to say, we'll take some from the crowd. Here, I'll work my way back. We can get everybody.
Is there concern for treating hypotonic patients with like low muscle tone with things like Botox or
Is there a
injections?
concern?
Yes.
Now,
furthering
actually, the
muscle weakness.
Botox itself, if you do it correctly, it's actually kept in a specific area. That's why they tell you when they do it, don't rub your face, don't exercise, because actually you'll stay right in that area. Now, if you rub it, it'll cause it to dissipate. Botox has been indicated in possible bone degeneration, but it has to be when it's in the system, not just in the specific area.
So getting someone who knows very carefully how to place Botox is important.
It's important. And that's correct.
Thank you. Who's next? All right.
When you're injecting Botox for TMJ, do you also do the trapezius muscles? And do you do it under X-ray, or do you just use half-inch or inch needles when you do that?
I'm sorry, I didn't hear the last portion.
Do you do it under X-ray when you do your injections, or do you just and do you inject the trapezius muscles as well?
Well, when you inject a trapezius muscle, it's usually on the crest. Okay? And what you do is you actually feel the trigger point. And what you're doing is shooting the trigger point. Now, as far as X-ray goes, you got to keep in mind that when you come right behind your clavicle, and you actually can feel the depression there, your lung is only about half an inch away. So number one, you're going to use a short needle when you do the trap, and you do specifically in that spasm area. You don't actually penetrate further down. But usually you don't have to do X-ray.
What about a patient with scoliosis? Would you do it there too? That has
Scoliosis?
TMJ and scoliosis?
Scoliosis is a whole different situation. That's the positioning of the vertebrae themselves. So there's really no reason to inject that with Botox.
So you mentioned about chiropractic work and just being careful about and C3 and up. Would you recommend the same thing for network chiropractic, specifically network being that it's more gentle touching along the spine and the body sort of learning to correct its subluxations, so it's not the manual manipulation that's harsh?
The answer is yes, there are chiropractors actually physically trained to that. They don't do high-speed adjustments. They're usually called nuntial chiropractors. And they're actually made to actually work up the superior spine. The answer is fine.
Okay, so they could work with C3, 1, 2, and 3 and
Yeah.
be okay in
It's
that
just,
realm?
it's just the traditional chiropractors that do the high-speed stuff. You don't want that, okay? Right.
All right, we're going to squeeze in it. We're at time. We're over by a minute, but we'll squeeze in one more question, and then others might be able to go find Dr. Mtakides if he's around. Thank you.
So you mentioned about the larynx spasms. I'm not sure if I'm observing this with my fiance, but I think she has neck spasms that actually make it so she can't breathe for up to 10 seconds at a time as if she's being choked. Is that the phenomenon is that a manifestation of that phenomenon?
Well, the phenomenon, believe it or not, is usually compression anywhere from C3 to 5, C5 in the neck, because those are dorsal root ganglia that actually go directly to the trachea and to the inferior portion of the pharyngeal space. And it's actually causing a stricture. That's probably what our situation is. But you're actually going to have to actually see what and where the spasms are and what's producing it. That's the biggest thing that you have to physically go after. Okay?
Okay.
All right, thank you very much, Dr. Mtakides.
Thank you.